I have about 30 minutes. I might go a little bit over that for the presentation, but we'll get going here. So no disclosures, though this slide does take time away from my door to needle time of less than 30 minutes. So in the process improvement meeting, it will be deleted. So we'll keep moving on. So what we know is door to needle times, they do matter. We'll go through just common stroke mimics and just want to stress out that we're not looking for 100% specificity with use of TPA. If we are only giving TPA to patients who only have a stroke, we are over screening and we're missing some patients that may actually benefit from TPA. Throughout this presentation, the cases will be on the blue slides, and we'll be going through seizures, hypoglycemia, other altered behavior that could actually be a stroke, and then we'll mention some other stroke mimics as well. So we know time is brain, perfusion is brain is really what we're going to more now, simply because we have CT perfusion capabilities as well as MR perfusions. So instead of strictly relying on time, we're able to treat more patients based on their imaging results, and now more patients with thrombectomy. But what we do know is that as time goes on, our TPA effectiveness goes down. So the more we use TPA in that first golden hour, within the first 2 hours, which that's why we're pushing that door to needle time sooner and sooner to where now the goal is less than 30 minutes. When do patients actually arrive to the ER? This is pushing our time that they arrive, but still, if we look back to 1993, 94, about 23% of patients arrived to the ER within the first 3 hours. That did not increase significantly all the way until 2005, and new data from the Get With the Guidelines stroke data actually showed that we're still just right at 25% of stroke patients arriving within that first 3 hours. There is 35% within the first 8 hours. However, that's not changing significantly over time, despite our outreach efforts with recognizing the public recognizing acute stroke symptoms. We still want to be as aggressive as possible when they arrive to the ER. The AHA have target stroke honor roll, and this honor roll for advanced therapy, we're looking for door to device times less than 90 minutes for direct arrival patients, and transfer patients less than an hour, less than 60 minutes. This is for the endovascular treated patients. For our Elite Plus, this is where we're looking for less than 45 minutes, but really a door to needle time less than 30 minutes in 50% of our acute stroke treated patients. This is moving fast, gathering as much information as possible in order to accurately and aggressively treat our stroke patients. So our first case, 63-year-old female, has history of a renal transplant, presents with acute onset of trouble speaking. This was witnessed 35 minutes prior to arrival, came by EMS. On arrival, patient did have expressive more than receptive aphasia. She could get more words out than she had trouble understanding. She had a mild drift on the right, but was able to answer most questions and was able to follow all commands. So her NIHSS stroke scale was 3. This is where we get into the discussion of disabling stroke with a stroke scale greater than 4 is what TPA is approved for. But speech here is a disabling deficit, and we're concerned if this is presenting as an acute stroke, we need to try to treat as aggressively as possible for this disabling deficit. So here, the initial CT scan, what we found is there's definitely cerebral edema here in the white matter, but this is actually not a stroke. What we see is there's some large mass here that is likely resulting in causing the cerebral edema. If this was an actual stroke, the CT scan, again, not acute onset, But if the CT scan was done 24 hours to 48 hours later, we would see this large wedge-shaped infarct that involves the cortex. So by the time we have a large wedge-shaped cortical infarct on CT scan, the cerebral edema is now reaching out to involve the cortex. Whereas on this patient, there's a large mass. We can see the cerebral edema, the white matter disease, but the cortex here remains intact as part of on the initial CT scan. So what did this patient have? She was transferred in. She had an MRI scan, and again, on history, renal transplant, so she's on immunosuppressants. This lesion was eventually biopsied because the answer could not be obtained on lumbar punctures. And the biopsy results showed a fungal abscess that then she was on major treatment for. So this intracranial mass lesion, it can present acutely as a stroke mimic. It can be primary tumor, metastatic, can be an infection, as in this case, but that surrounding cerebral edema is what causes the symptoms. The symptoms often present after the individual patient threshold gets passed, that then results in loss and function of that area of tissue. So in this case, that cerebral edema passed the point to where then she had acute onset of an expressive more than receptive aphasia. Our second case, we have a 73-year-old female, lives with family, was noticed at breakfast to really be acting strange, or strangely. She's very different compared to last night at 9 p.m. This morning, she's bumping into walls, chairs, and when people were talking to her around the table, she was really trying to figure out who was talking to her. And then the weirdest thing they noticed is that she ate only half her food, which is not normal for her, so they decided to bring her into the hospital. So on arrival, her stroke scale was 7. She had a best gaze, a little bit of a gaze preference. She was more looking over to the right side. She did have a visual field deficit on the left side with left arm drift, some sensory loss, and then overall she had the neglect, ignoring the left half of the world. On our CT perfusion, what we can see is there is a right MCA cortical deficit. Here in green is our penumbra, and the red is our core infarct. So that core infarct is tissue that's already died as a result of the stroke or clot. And then here on CT perfusion, you can see the large area of penumbra that's still at risk. So this patient, her altered mental status was the behavior changes, but was noticed on exam to have the gaze preference and neglect. And then here's her angio, showing the large right MCA territory that's at risk of having a large stroke. Because of her last known normal last night is why she didn't qualify for TPA, but still qualified for thrombectomy given the good perfusion or penumbra data on the CT perfusion scan. So altered behavior here, this gaze preference is sometimes subtle. Family didn't really notice it at first, but the visual field testing on every patient that's altered can often help catch an important sign of a cortical stroke. So for this patient, there was those signs on exam on presentation, and then based on the history from the family, she was bumping into things on the left. I did leave that part out. See what I did there? Left? Yep. I like that. I'm not that funny though. So not speaking to family was on the left side of the table is who she was ignoring talking to her, and then only eating the right half of the plate. And that's when they decided this is too strange for their mother, so they brought her into the hospital. Moving on to another case, our time is still ticking away. We have a 55-year-old male, history of hypertension, diabetes, and stroke. He does have residual mild right-sided weakness, and he was found by family 45 minutes ago. Minimally responsive, not speaking, with right-sided hemiplegia, not moving his right side, right arm, or leg at all. 911 called family. On arrival, patient continues to have trouble speaking. He was starting to have some movement in the arm and leg, but not purposeful. And per EMS, they did notice some improvement in his right-sided from on scene. He was very weak, but started moving and trying to speak as they were coming en route. But with the continued weakness and speech difficulties, imaging was obtained, and he's never been to our hospital or our facility before. So his CT scan showed a large territory chronic infarct. But on CT perfusion, that infarct is not penumbra. It's already a completed infarct, and there's no areas of penumbra or loss of function surrounding that territory. So there is evidence of an old stroke that patient recovered well from, still moving, talking with only a little bit of residual weakness, but now is very different than that on exam. As we go back into further history from family, now that they have arrived to the ER, the stroke was 20 years ago. He's done well. And family, they did leave to go to the store. So when they initially called, time last known normal was thought to be 45 minutes, but it was actually 2 hours prior to that is when they left for the store. They had noticed that he had bit his tongue and also had urinary incontinence when they found him on the couch. On repeat exam, he was starting to wake up, returning back to baseline. And at that point, of course, he wanted to try to go home. So seizure with prolonged post-ictal state or TOS paralysis. This is a case where there's actually an old stroke that led to recurrence of the same prior symptoms or recrudescence of these symptoms. But seizure by itself can cause a focal TOS paralysis where patients can arrive with these localized deficits of speech trouble, right-sided weakness. It can cause severe neglect with left-sided weakness as well. The patient improving on exam, or what often happens, they have a recurrent seizure, whether it's on the CT scanner or sometime during that initial evaluation. And then history, looking for tongue biting, history of urinary incontinence or seeing the urinary incontinence on arrival. And if there's any witness to this, whether it's at the bus station, at home, at work, if there's any history of jerking, rhythmic jerking at onset. Seizure itself, though, is not an absolute contraindication for TPA. It's something where patients who have TOS paralysis, we like to see them start to improve. If we're concerned that they're in status, that's another treatment paradigm. But if somebody has a large cortical stroke with a large clot, that could actually trigger a seizure. So you would want to try to monitor and see this is patient's not fluctuating at all. That may lead you to more realm of treating, and that would actually then show up on our advanced imaging with CT perfusion or CT angiogram showing a large vessel occlusion. There's a 55-year-old female this time with history of hypertension, diabetes, stroke, residual right-sided weakness, was found by family 45 minutes ago, minimum responsive, not speaking, right-sided hemiplegia. 911 was called by family. It's the same story. Deja vu could be a warning sign for temporal lobe epilepsy, but this is actually, we sometimes have themes that come into the ER. So this is a theme of identical patient, just female instead of male this time. On arrival, continue to have aphasia, no movement in the right arm and leg, and per EMS, no improvement during transport. And with that continued weakness, speech difficulties, again, advanced imaging was obtained. And this is the exact same image, again, showing evidence of an old chronic infarct in the left hemisphere, but no area of hyperperfusion or penumbra looking like there's an evidence of a large vessel occlusion. And of course, while they're on the CT scanner, the initial labs come back, the blood glucose was down to 26. Patient now, family arrives, and her stroke again was 20 years ago. But with her diabetes, she's had a poor appetite the past few days, didn't eat breakfast or lunch, and still took her long-acting insulin last night. So with those initial labs, patient did start to improve after getting the AMPA D50 infusion. So hypoglycemia, even without history of a prior stroke, it can cause focal neurologic deficits, but definitely in patients with prior chronic changes on their CT scan, hypoglycemia can then cause recrudescence of the prior stroke. And now we're getting to the toxic metabolic disturbances and a long list of things down here that can then cause recurrent symptoms of the prior stroke, whether it be a urinary tract infection, acute kidney injury, post-dialysis, hepatic encephalopathy, medication effect if they were started on a new medicine. These are all things that can cause acute disturbances, and then finding out that there's a lab abnormality or something that acute that has changed is what then is leading to recrudescence of the prior stroke symptoms. This clock is just keep ticking away as we're getting closer to our 30-minute timed gold door to needle time. So next patient, we have 63-year-old male, history of hypertension, diabetes, chronic coronary artery disease, chronic kidney disease, which is stage 3, and a current smoker. He was brought in by family for acute change in mental status. He dropped his family off and then went to park the car for a Georgia Tech football game. And then he was found when he didn't show up at the seats. They went looking for him, and he was found wandering around the parking deck. He was confused. They called 911, got to the hospital, and he was, again, not focal, able to move everything, was speaking clearly, moving all 4 extremities, so the stroke scale itself was 0. CT scan, CT angiogram was done, was actually normal, and then on repeat exam, he was able to repeat these short phrases, answer questions correctly, but he continued to ask the exact same questions, whether or not it's these 2 or 2 different questions, or how did I get here? What am I doing here? And you answer, he seems to understand, but then 3 minutes later he asks, but where am I? And how did I get here? What am I doing here? These are patients that they will continue to ask these same questions throughout this full episode. During the ED course, patient returned to baseline, had no other lab abnormalities. The Georgia Tech game was actually on TV, and he noticed it, and he said, wait, that's where I was supposed to be. I still have time to make it for the second half if y'all discharge me in enough time. His family wanted him to complete the full workup, so he did stay and had to finish watching the game on TV. What he had was transient global amnesia. This is an acute onset of antegrade memory loss. The confusion comes with being lost to orientation to place and time, but most of them, they all remain oriented to their person and can recognize family and most friends. Sorry, Carol, you didn't make the list. This is something that lasts. The longest that I've personally seen in the ER is something lasting up to 5 hours. But the episodes can last up to 24 hours. They're often just that recurrent questioning over and over again, the same questions until the episode starts to go away. Sometimes patients can have known triggers, migraine, seizure. Patients with history of migraine, this can often present as their aura. Seizure, this might be their first new onset of seizures. Hypoxia, psychological stress factors can sometimes trigger these events, but it's not something where we definitively have an answer to what is the cause for transient global amnesia. There are patients on occasion where an MRI scan is performed, and you can often find a punctate small area of ischemia in the hippocampus. It's something where it's not common. Sometimes the MRI scans are completely normal, but there have been multiple case reports with a small punctate infarct seen in the hippocampus. Whether or not that's triggered by seizure and just local hypoxia leading to those small areas of punctate ischemia, still this is something where it's a stroke mimic, not something I would typically give TPA for unless there's added symptoms of weakness, focal weakness, or other deficits. In the other common mimics, we have complicated migraine, and these patients often have multiple prior episodes. By the time they're in their 20s or 30s, they know that this is their migraine symptoms. they themselves tend to stop coming into the ER. But if they have aphasia as their neurologic deficit, and they're at work or they're not around family members who know that this is their history with migraines, they'll present as acute stroke symptoms. And if symptoms aren't improving, patients will still qualify for TPA, especially as speech is a disabling deficit. But even if they had the hemiplegic migraines with unilateral weakness, these are patients where they'll meet criteria for TPA, imaging will appear normal, and we'll have treatment for, we'll receive the TPA, though then later as a patient's waking up or we gather more history, that's when we find out it's ultimately a complicated migraine. Encephalitis, again, can be a mimic for stroke. Here there's often a prodrome of some viral syndrome, whether it's new onset of headaches, possible fevers, just generalized malaise, prior to acute onset of symptoms. In that case, we'll be worried about a seizure triggering the acute deficits. And this is my opinion, that's why I marked it in red, that again, if we're only treating stroke patients with TPA, we're over-screening, and we found reasons not to treat instead of our goal to treat patients and find reasons to treat stroke as aggressively as possible. So these stroke mimics, again, this lecture is not meant to discourage use of TPA, not meant to delay the treatment with TPA. It's try to improve awareness and focus our neurologic assessment on why are we doing different portions or different parts of the exam during that acute evaluation. This one image on our stroke cards or stroke sheets, information on our phones, this one image not only will pick up language deficits, but it can pick up visual field deficits and neglect, where patients who are altered behavior, whether they're bumping into things at home or they're just not acting right at work, and they read and they describe this image and they don't tell you about the kid that's going to need to see neurosurgery after falling off a stool, that's left-sided neglect and then would be able to be captured as a disabling deficit for stroke. So going through this image not only is a language test, but also will help check for neglect. How best to avoid missing a stroke with these stroke mimics or patients who show up altered? Language testing, again, on everybody who's altered as best as possible. Repeating a single word in a short phrase, as well as naming some objects. Doing those short portions of the exam will help pick up a receptive or expressive type of aphasia. Following simple commands, asking them to show 2 fingers, asking them to close and open their eyes, things that are on the stroke sheet. But again, if we're performing on everybody who's altered, we'll be able to try to capture these these major deficits. Visual field testing, again, counting numbers. If somebody's altered, they're not going to be able to count numbers, whether you're showing 1 finger or 5 fingers, and they have to be alert enough. But blinking to confrontation or blinking to threat bilaterally, you can check that on every single person who's altered because they're going to have some type of flinch or some type of reaction to that. And we want to make sure we're not doing a corneal sensory test. So if you're blowing air onto the eye, they're going to have a blink whether they saw the hand or not. So you want to try to come in and threaten their eye where they'll flinch or turn away from it. And then you can do that on both sides to try to capture what can be a major cortical deficit or signs of a major stroke presenting with their altered mental status. So I think I am below my time, made the door to needle time within the 30 minutes. So thank you for your attention. If there's any questions, comments, or concerns, please let me know. And this is my son, Pax, in Washington State. We were on vacation.
It's so cute. So I'm going to check the chat box. If you have any questions, thank you for the awesome presentation, Dr. Anderson. That was great. And I'm sure even the people that were not able to make the call, once we send out the recording, they may have some questions as well. So we can share your email with them if they have any other questions.
Absolutely.
Okay. So
I have a question. Can you hear me?
Yes.
Great. So Aaron, this is Mike Frankel. Wonderful presentation. It's, you make this difficult decision tree seem very straightforward and easy, which is terrific. And, sometimes these are really difficult decisions to know stroke versus no stroke. And I think you made a good point about, if the patient meets criteria and it might be a stroke, it's still worth treating if they meet the inclusion and exclusion criteria. And then your last points about the patient who doesn't have any motor weakness, they move everything, but they're confused, and how difficult it is to tell the difference sometimes between confusion and aphasia. And the simple tests that you suggested, naming, repeating, and I think that's a really good suggestion. And doing that on a lot of patients, getting a feel for what naming and repeating is like in a patient who is has some kind of toxic metabolic problem. They're sick for other reasons. So you can get a feel for what naming and repeating is in a patient like that versus a patient who clearly has aphasia. And it just takes time to really get a feel for whether somebody has aphasia or not. And it can be very difficult. The visual field test is so difficult to do in an uncooperative patient that might have a stroke that doesn't have any motor deficits. So your suggestions about how to go after the visual field on each side to look for a visual field defect in those patients was also helpful. So thanks again. I'll stop and see if anybody else has any questions.
we do have one comment from Katie Collins, and she says, "Thank you for the presentation. I appreciate the mindfulness of time elapsed for the presentation and achieving door to needle in less than 30 minutes."
Yes.
Yes, very good point. Do we have any other questions? Just a reminder, you will have to unmute yourself if you have a question. So you should be able to click on the unmute button by your name. Okay, I don't think we have any other questions, so we will go ahead and end the call there. I'm just going to check the chat one more time. Is Terry still on the call? Terry Newsom?
Yes, I'm here, Denise.
Okay, did you have anything?
Only thing is that I did notice that we had 76 participants, but we only had 31 in the chat. So I just want to make sure that everybody did get credit for participating. I want to thank him for a wonderful presentation. We have had many, many requests for this topic, and I hope that it's very helpful for people. In addition to that, when the recording comes out, please make sure that you are sharing it with your bedside EMS staff. This does go out on our EMS listserv, but our EMS contacts have grown. They've over doubled in the last year, and I just want to make sure that we're reaching the right people. So if you'll help us with that, that would be wonderful. This is a very useful presentation for them. And again, thank you so much. And thank you, Dr. Frankel, as well, for reaching out to your peer.
Yes, if you have not entered your name, your facility name in the chat box, please do so. And again, the call will be recorded and shared with the Coverdell and EMS listserv for you to share with your partners. And just one more time, do we have any other questions before we end the call?
I have another question. Can you hear me?
Uh-huh.
So one question that someone texted me, it was, it's a really good question, and it's going to be a tough answer, Aaron. But what do you think a good percentage is of all TPA-treated patients who are mimics? Can we use that as a guide for in some way to say that we're not missing opportunities, but what percentage? You kind of go from your own experience. I'm not aware of much in the literature that tells us you should have a certain percentage of mimics in order to be considered, adequate in your decision making. What do you think?
Right. I think it's, it's not something I've looked for a specific percentage. And to say that 10% might seem a little bit too high for me. If you're 10% of your stroke treated patients were actually mimics. But if you're in the 3 to 5% that got TPA actually turned out to have a stroke mimic, it's something where there's been reports that stroke or TPA is safe in normal brain. So patients with the complicated migraines with these other mimics, if we're treating aggressively for the likelihood that they had a potential life-changing clot or life-changing disease, then that percentage and that aggressiveness does pay off with being aggressive with all the other stroke patients.
Thank you. I'd agree with that too. I think that's a good percentage, that 3 to 5% mark.
Okay, and just a reminder, the next Coverdell call will be October 7th, and we're always looking for ideas on things that you're interested in learning more about. So if you have any ideas on topics that you would like covered here, please email me. Denise Fluid is DENYS.fluid, FLUITT @dph.ga.gov if you have topics that you're interested in that we haven't covered here. And also if you have any ideas on speakers for those topics. So please let us know if you're interested in hearing topics, or if you've had conversations with other Coverdell partners about potential topics. So if we don't have anything else, we will see you all on October 7th. Thank you again, Dr. Anderson. We appreciate you.
Very welcome. Thank you.
Taken off the entire week.